Good morning, everyone. And today, our topic of discussion is liver function test or LFTs. And this is again a very common test which is ordered um, daily, okay, in hospitals and clinics. And of course, as the name shows, it is just to check the functions of the liver. Now, of course, first of all, I would like to show you how it looks like. You can say like this is a sample of the report of liver function test, and I wanted to show you what are the things they measure and they give us. So basically, of course, like not all of them they give all the results, but um, I will tell you, uh, there are six main measurements which we get. One is bilirubin. Okay, so bilirubin. Now, if you know what is unconjugated or what is conjugated bilirubin, or which is also called as direct and indirect bilirubin, so they give us simply direct and indirect, or you can say the conjugated and unconjugated both readings in the results. As well as they give the enzymes results, for example, ALT or alanine transferase, which is present in the liver cells, as well as AST or aspartate transferase. And if you will see again, see the same thing, alkaline phosphatase are over here as well. Okay, other than this thing, there is something which is not given over here. They give us a value um, depending on the lab. For example, they can give you the value of GGT. So what is GGT? It is glutamyl transpeptidase. Okay, GGT, glutamyl gamma GGT. G for gamma, then G for glutamyl, and T for peptidase, and they give us the value of albumin. So see, albumin and alkaline phosphatase are playing role over here as well. Some of the labs they also give us prothrombin time. So prothrombin time, like, I'm not talking over here because that is also a part of coagulation profile. So we are going to discuss it over there. Now see, guys, the concept over here. Liver is the one which produces almost all the proteins in the body. So albumin is one of the proteins, right? Um, some of the labs they do give us the levels of globulin as well. So remember, globulin is also a type of protein, right? So simply they gave us the protein levels and all this fun. Now, uh, again, for many who don't have forgotten the basics, um, um, though like this is one of a very important basic concept which you must remember. And again, I would take the name of the book Guyton, if you don't know, so go through that, because we need uh, to understand this thing completely in order to understand what is bilirubin, what is conjugated one, what is unconjugated one, and it is going to come again and again. No matter you are studying internal medicine, you are studying pharmacology, you are studying pediatrics, these tests are going to come again and again. Whenever there will be liver diseases, you have to go through these things. So as we know that the bilirubin is a breakdown product which comes from the RBCs. So when the RBC cells are destroyed in the reticuloendothelial system, what happens? That the globin part, which is a protein part, it enters into the protein metabolism, and then there is heme part, which is further broken down, and bilirubin is released. Okay, so the bilirubin, which is the unconjugated form. So remember, the unconjugated form of protein is basically not water soluble. So simply that one is taken to the liver, and in the liver, what happens? Uh, okay, and that one is transported from to the liver when it is attached with the albumin. So now the liver is the one which basically do conjugation. So as we know that it is conjugated with glucouronic acid, or you can say there is a enzyme, okay, which causes this conjugation. So, so after this conjugation, this conjugated bilirubin is released, is secreted into the bile. Okay, and from the bile, it is going to enter into the intestines. Okay, in the intestines, what happens? Like basically, again, the conjugated bilirubin, the glucouronic acid is removed by the bacteria. Okay, and the resulting bilirubin is, we call it as urobilinogen. So urobilinogen is the water soluble one. And now what happens? Like much of the bilirubin which is from here, we will lose it in the feces as stercobilin, and the rest, which can be absorbed in the blood, much of that, it goes into the enterohepatic circulation, or which we call it as urobilinogen cycle. So some of the reabsorbed will be basically uh, recycled. Okay, and the other one, like by the, it will enter into the blood, it will reaches to the kidney, and the kidney are going to release it in a form of urobilinogen. So like it's like these are all the things, the cycle of bilirubin. Uh, Now, indirect bilirubin is basically the unconjugated one. So, for example, whenever there is any pathology, whenever there is any pathology before the liver, it will result into the increase in unconjugated bilirubin. And whenever there is pathology in the liver, or for example hepatitis, there will be increase of what? Conjugated bilirubin or direct bilirubin. As well as, like when the liver cells will be damaged, what will happen? Like the enzymes which are inside the liver cells, like AST and ALT, they will be raised as well. So anyhow, like this is the like as I told you, this is the most simple concept which I wanted to show you. Okay, uh, like the cycle to understand like what are the liver function tests they do. So now I will talk about each of these things individually, and I will talk about what will happen in these patients. Now, guys, one of the thing to remember over here, bilirubin. Okay, so remember like the causes of jaundice, right? Or the causes of increased bilirubin level in the blood, which is called as hyperbilirubinemia. So the bilirubin can be raised in the blood in, there are three main reasons. One is called as prehepatic reasons, right? Causes. One is called as hepatic causes, and one is called as post-hepatic causes. So, what is prehepatic causes? For example, if your RBCs are broken down more, so there will be more and more bilirubin which will enter into the system, and when your liver cannot hold up that bilirubin, so they will started appearing in the blood and will lead to hyperbilirubinemia. But what form in this case? Unconjugated. Okay, so unconjugated hyperbilirubinemia, because much of the unconjugated one or indirect one will be present in the blood. I told you one of the examples is called as hemolysis. So that's why whenever they give us the results of bilirubin, they give us both conjugated as well as unconjugated one. Now comes the hepatic one. For example, a very common example is hepatitis or the inflammation of the liver. So whenever like there is inflammation of the liver, so what happens? Like the cells of the liver become inflamed and they become leaky. So what happens? Like AST and ALT enzymes will be spilled out in the blood. They will be raised. Same time, what will happen? The conjugated bilirubin, which is hold in the liver cells, they are going to leak as well. So it will result into what? Conjugated uh, hyperbilirubinemia. And now, guys, if you know, and if you have listened to the lecture of mine, which I give in physical diagnostics. So in that one, I talk about whenever we see any prehepatic, hepatic, or post-hepatic patient, we always ask the color of urine and the color of feces. Why? Because when there is post-hepatic obstruction, for example, someone who have biliary atresia or choledochal cyst. So they have increase in conjugated hyperbilirubinemia. Okay, so of course, like their feces will become pale in this case, right? So this is how we go for that. So this is about bilirubin. That's why we see unconjugated and unconjugated one to differentiate between prehepatic or hepatic causes or post-hepatic one, and we correlate this one clinically with the sign and symptoms. As far as AST and ALT are concerned, uh, AST, oh sorry, AST, ALT, and ALP, right, guys? AST, which is also called as aspartate transaminase, and one more test which is the same one like bone, ALP, which is alkaline phosphatase, right? Now about these tests, I already told you that ALP is present in the bone, in the liver disease, in the GIT disease. So remember, ALP is not specific for liver. It can be raised in liver conditions, it can be raised in bone conditions, it can be raised in myocardial infarction. So simply, this is not specific to liver condition. AST, which is aspartate transaminase. Okay. Now, what is the story of AST? Now, AST, like ALP, I already talked about this one in the previous lecture, but AST, now, AST, uh, now AST is present in liver and also in muscle. You understand? So that's why AST and ALP, you can say, are not specific to the liver or liver damage. So, for example, AST can also be raised in muscle injury, or you can say even cardiac muscle injury. For example, myocardial infarction, you will find raised ALP as well as raised AST. Okay, so that's ALP. I'm not discussing. I discussed in the previous lecture. But guys, remember this thing that ALT, and very easy way to remember this thing is what ALT is specific for liver. Very easy way to remember. ALT have L, so liver starts from L. So remember, L goes for L. So alanine transferase is specific for liver damage. So whenever ALT is raised, think about what you can say, liver damage. So now remember this thing. I already told you the story of bilirubin. Why we go for the conjugated and unconjugated one? Because we have to differentiate between prehepatic, hepatic, or posthepatic. Now, of course, if it is posthepatic, there is mostly due to obstructions. We will go for imagings, right? Alanine transferase, okay, they are present in high concentration in liver. Okay, alanine transferase, they are also present in kidney, they are also present in other tissues, but mostly they are present for in liver. Okay, so that's why whenever there is any kind of liver injury, or you can say raised in liver injury, okay, so whenever we have to check liver injury, for example, someone who will come to me with the complaint of jaundice, I am going to check his ALT. Okay, I am going to check his ALT. So it's it is present. It's not like this that this is just present in the liver, but it is present in other tissues as well, like kidney. Okay, But okay, one thing, guys, remember this thing: ALT in minor form can be raised from other things, but when it is raised more than 500 international units per liter, it is highly due to liver damage or liver causes. Okay, like hepatitis. Okay, or like any kind of liver damage. So this thing is important. So some of the lab reports, they also give us the ratio of AST with ALT. Now what is this ratio is important is simply whenever the liver damage is due to alcohol, AST is raised more than ALT. But whenever the liver damage is due to other causes, ALT will be raised more than AST. Okay. So remember, alcohol is spirit. So as for spirit, so remember, alcohol is spirit. So in alcoholic causes, AST will be raised more than ALT. So that's why some of the labs, they do give us the ratio or AST ALT ratio simply. Okay, this is like how they give. So like simply, you can say uh, that one of the thing that whenever you found that the AST is raised more than ALT, think about the alcoholic conditions. Okay, so this is the important thing. But whenever uh, the liver damage due to other causes, ALT will be raised more than AST. Okay, so this is a very 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 important concept, right? So remember this point. Okay, now guys, the important thing over here. See, when we do liver function test, okay, you can say whenever we do liver function test, of course, liver function test will give us what, you can say the liver function test can guide us towards either there is any liver damage going on or not. So simply, um, if you can say if the LFTs are abnormal, okay, so it implies or uh, it shows some liver damage is there, right? Especially when AST and ALT will be raised, not just the bilirubin, because maybe in hemolysis there will be raised bilirubin levels, but in that one the liver is normal, okay. But the rise is due to increased breakdown of RBCs, right? So now LFTs will just tell you that the liver damage is going on, okay, with the raised ALT and AST. So of course it will guide us to further testings to diagnose the, why it is like this, okay, oh, sorry, testings to diagnose the exact disease, right, which is causing the liver damage. Okay, before going on that, uh, okay, leave that. I will be able to discuss that thing later. Okay, so now I'm going to show you, for example, uh, sorry, okay, you can see over here that there is a disease called as autoimmune hepatitis. Now, what is autoimmune hepatitis? Of course, it's inflammation of the liver due to autoimmune conditions. So whenever we get like LFTs are abnormal, what further testing are needed? You will do the testings of autoantibodies. Okay. So if you found, if when you will order an autoantibody screen, By the way, you can go in the playlist Internal Medicine Rheumatology. You can find a lecture about auto antibodies. Okay, so whenever we found LFTs and we are expecting autoimmune hepatitis, we order a auto antibody screen. And when we get some specific antibodies, for example, if we get anti-mitochondrial, it makes a diagnosis of primary biliary cirrhosis. And of course, we can do biopsy also. Or for example, if it's a celiac disease, so we can get anti-transglutaminase antibodies, and we will go for the colon biopsy, right? For example, if the liver damage is due to a condition called as hemochromatosis, which is a disease of abnormal iron metabolism, so we will order iron profile, and we will found high iron, ferritin, and transferrin saturation, and low total iron binding capacity. For example, if we will found the sign and symptoms of Wilson's disease, there is many things which are present in Wilson disease. For example, there could be some abnormal movements called as chorea. There could be some signs in the eyes, joint problems in both can occur. So we are suspecting Wilson's disease, we will order copper studies. So we will found if we will get low cellular plasmin and elevated 24-hour urine copper concentration, it is suggestive of Wilson's disease. And same thing when we are suspecting viral hepatitis, so we will do viral hepatitis screening. We will check for hepatitis A, B, C, D, or whatever type we are looking for. Um, the same one. So I was on viral hepatitis screening. So, for example, if we are suspecting there is a condition called as alpha 1 antitrypsin deficiency. So these are the people, they have multiple lung and liver problems and other bodies. So we will check alpha 1 antitrypsin in the blood, we will get low levels. For example, when we are suspecting someone with hepatocellular carcinoma, we will check the alpha fetoprotein. And this will be my lecture about, the next lecture is about tumor markers. So this is one of the tumor marker. It will come back as high level. For example, if we are some other conditions, so we will look for specific immunoglobulins. So simply LFTs will guide us towards other testing. Now, guys, the important thing is I already told you, like, we divide the conditions broadly into three: one pre-hepatic, or hepatic, or post-hepatic. Okay. And now I will go on to the post-hepatic causes, because we have to go or talk about gamma glutamyl transferase and alkaline phosphatase mainly. So simply we do LFTs because it narrow downs the differential diagnosis which we have in our mind. It guide us towards further testing to look for other liver conditions. Okay. So whenever like the hepatocellular damage is there, AST and ALT spill out, right? So we have already know this thing. A very easy way to make you understand this thing. See, liver cells or hepato cells. Okay. So whenever that liver cells or hepatocellular damage is there, it will become inflamed. Okay. And the cells become leaky. And when the cells become leaky, so whatever is inside will spill out. So what will happen? AST and ALT will be raised because now they spill out in the blood. Okay. Before they were inside the cell. Now, whenever there is, you can say, obstruction, there is obstruction to the bile flow, okay, from the liver. Like the liver is made up of what? Like there is a biliary tree, and it comes out from the liver, connected with the gallbladder, and then goes and is connected with the pancreatic duct and make common bile duct, and it is going to drain out in the second part of the duodenum. So now remember, guys, when there is obstruction in the bile flow from the liver, We call it as uh, we call it as um, biliary stasis or cholestasis. Okay, so cholestasis means what? Like the bile is static now. Okay, the bile is static now. Cholestasis is there. Now, basically, the cells which are lining the biliary tree, okay, or biliary ducts, you can say, have ALP or alkaline phosphatase. Okay, so whenever see these cells are damaged, what will happen? Alkaline phosphatase are going to release in the blood. Okay, uh, one more thing, the biliary epithelial cells, epithelial cells, okay, which have ALP, epith, epithelial cells. Okay, I hope like this is the correct spelling. Also have one more enzyme. Also have gamma glutamyl transferase. Understand, guys? So whenever there is damage to the biliary tree, what will happen? ALP as well as GGT, they are going to spill out in the blood. Okay, so this is the most easy way to tell you this thing. So guys, see, when hepatocellular damage is there, ALT and AST will be raised. But whenever what you can say, uh, obstruction to the bile flow is there, right? Whenever the obstruction to the bile flow will be there, or we call it as what? Cholestasis or cholestatic pattern. So remember, whenever there is damage to biliary tree or cholestasis, of course cholestasis is also damage, so stasis is there, it will cause what? It will cause raise in ALP and GGT. Okay, so this thing is important. So now uh, uh, there are conditions, for example, when ALP, GGT, AST, and ALT, they will be all raised. Okay, why? See, because when the biliary tree is obstructed, of course, the bile or the this coli or the bile is going to accumulate it inside the biliary tree, which will cause back pressure on the liver cells. So when there is back pressure on the liver cells, it is going to cause damage to the liver cells. So it will lead to raised AST and ALT as well. So cholestasis can further cause liver damage. Okay. So this thing is important. So whenever, guys, there is post-hepatic or conjugated hyperbilirubinemia, okay, um, and we found that there is increase in GGT and ALP as well. So we call it as what? Like there is cholestasis or there is post-hepatic type of jaundice, right? So, for example, you can say, we can talk in this way. What are the causes of cholestatic uh, jaundice? Cholestatic jaundice, right? So, number one is obstruction, right? Now the obstruction, the most common cause of obstruction is what? Bile duct gallstones, very common in females. So this is like the cause of biliary obstruction, right? Uh, there could be an abnormal bile duct wall. For example, in if there is a stricture is there. Okay, stricture in the bile duct wall. Or for example, there is cancer, or we call it as cholangiocarcinoma. Okay, that will lead to this thing. And number thing, for example, the bile duct is compressed from outside, or you can say compression of the bile duct from outside, right? Now, if you know the anatomy, what are the structures around, you can know. Pancreatic carcinoma can lead to this thing. Okay, carcinoma will lead to this thing, or sometimes it could be, you can say, ampullary carcinoma. And there can be many tumors and things like this which can compress the bile duct, right? So of course they will lead to post-hepatic jaundice. They will lead to increase in the level of GGT and ALP as well. So I hope you guys understand this lecture, guys. Not so hard, just important thing. And yes, the last thing is albumin. Remember, guys, liver is the one which manufacture all the proteins. So remember, whenever the liver is not working fine or there is liver failure, this will lead to the low level of all the proteins, not just albumin, even the clotting factors. Okay, so albumin we measure because of that. So we will talk more about that thing in clotting factors. Thank you so much, guys.